Okay, so hello, my name's Michelle. Thank you so much for coming. We're really excited, and you can just start whenever you're ready.
Okay, so I'm going to share my screen so that you can see my presentation, okay? Okay, you can see my presentation, right?
Yes.
Okay, perfect. All right. Hi, everybody. My name is Dr. Hardeep Kataria. I'm an optometrist. I practice in Los Angeles, California, and today I'm going to be talking to you about what an optometrist is, how you can qualify to practice as a doctor of optometry, and we'll go through some patient cases as well. Okay, so firstly, no financial disclosures or cases presented, and associated information is my work and patient cases, and no HPI will be associated with the cases that is disclosed. So I graduated with a Bachelor's of Science in 2008 from the University of Florida, and then went on to um, my Doctor of Optometry degree at the New England College of Optometry, and did a 1-year residency in ocular disease at the University of Maryland, Baltimore, VA, and then completed my fellowship at the Academy of Optometry in 2016. Okay, so um, typically as an undergraduate student, you would take pre-science requisites and courses as you would do for medical school or dental school or most of the other science-based healthcare professions. So that includes your bio 1 and 2, your basic chemistries, your organic chemistry, your physics, your calculus 1, 2, and 3, statistics, economics, those types of courses. As with any of the other professions or the graduate schools, you can choose your major as long as you have fulfilled those prerequisites, and you can find that information at each of the optometry school websites as well as to exactly what they want to see. So what is a doctor of optometry? Well, a doctor of optometry is the frontline primary eye care provider. So optometrists, they examine, diagnose, treat, and manage diseases and disorders of the eye. They play a major role in the individual's overall health and well-being by detecting systemic disease such as diabetes and hypertension. So in a nutshell, what this means is that the eye doctor is a very important part of the primary care conversation because the doctor of optometry is the primary eye care provider. So how do you become a doctor of optometry? Well, this is separate from a doctor of medicine, so it requires a completely different medical professional track once you have graduated from your undergraduate program. So it's 4 years of an undergraduate degree, 4 years at an accredited optometry school, and then a 1-year residency, which is optional. And then you can specialize further, which is also optional, by becoming a fellow or a diplomat of the American Academy of Optometry. If you also wanted to, you could stop right at the 4 years after optometry school, and you would be a graduated doctor of optometry, and you could enter practice right away without a residency. So for those of you who are considering both tracks, that's one of the main differences between doctor of medicine and doctor of optometry. So where can I practice as a doctor of optometry? Well, you might be familiar as a child with your Target Optical, your Costco Optical, your lens crafters. We call that an optical, a corporate or retail setting. So that's one of the most common where a doctor of optometry can practice. The most common is the private practice optometrist. So that's your family eye care practice that is run by an optometrist, and they have other optometric associates working with them. Then you have a multidisciplinary setting where an optometrist can either work with other physician colleagues, such as primary care, internal medicine, family medicine, and pediatrics. And then you can also have an OD/MD setting where you are the OD, the doctor of optometry, working with the ophthalmologist, which is my situation. And then you might have certain specialties within ophthalmology, and then enter the optometrist, where I have my specialty in medical optometry. You can also practice in a hospital setting. So typically an optometrist is not a hospitalist per se, unless you're at the VA in the VA system. So in that case, then you would provide inpatient and outpatient care as the doctor of optometry on staff at the VA setting. You can practice at an academic institution where you are a part of the faculty, either professor, assistant professor, that kind of thing. I've done that too. You can work in the public health sector, for example, at your FQHCs, such as your community health centers. So those are your nonprofits. You can be a consultant in the industry, just like you can with a doctor of medicine degree. If you decided that you did not want to pursue a residency, you could enter the industry and become a consultant. And then, of course, as a doctor of optometry, would also practice in the military. So once you have graduated with a 4-year Doctor of Optometry degree from an optometry school, then you can choose to pursue an optional residency. So an optometry residency is a postdoctoral educational program centered on clinical training that results in the resident's attainment of advanced competencies in eye, vision, and healthcare. So what does that mean? That means that you are thrown into a very fast-paced, highly clinical setting where you are gaining experience that's worth 3 years of being out on your own. So you can choose to do that residency. You can pursue a residency in primary care, ocular disease, cornea and contact lenses, pediatrics vision therapy, and neurovisual rehabilitation. So primary care and ocular disease can sort of go together, because this is where you would learn how to treat your very advanced cases of glaucoma, uveitic glaucoma, angle closure glaucoma, primary open glaucoma, how to kind of set target pressures for patients, how to give them different combinations of eye drops. In certain states in this country, optometrists can also perform lasers for optometry as an optometrist for glaucoma patients. And so that would fall into that residency where you would learn how to do that in primary care and ocular disease. Cornea and contact lenses is a great residency program. A patient who is maybe post-corneal transplant, a patient who has keratoconus, a patient who has very advanced dry eye disease, a patient who has a graft rejection on the front of the eye, so that's graft versus host disease. All of these conditions would be fit by a residency trained contact lens and cornea specialist optometrist. Then you've got pediatrics and vision therapy. So pediatrics is a very interesting area of optometry to practice in. Some babies have congenital glaucoma, some have congenital cataracts where they need to have surgery at a very early age in their lives because they're born with these conditions. Well, after that condition has been resolved or treated by the pediatric ophthalmologist, they need to rehabilitate their vision so that you're providing the best opportunity for that pediatric patient to have vision, usable vision, and optimize their vision for the future, and so that their brain develops and their eyes develop. And so you have hard contact lenses for a 3-month-old and a 6-month-old, and that's what a pediatric optometrist would do. If they've had, maybe they need a special pair of glasses because they've had an eye turn correction, so they had a strabismus surgery when they were very young. Maybe a patient has one eye that doesn't see so well. That's where vision therapy comes in. Maybe the patient has an eye turn that's not surgical, but they just need to kind of train their eye muscles to work together. That's where the vision therapy would come in. Maybe a patient has had a traumatic brain injury, and the most common condition that comes with a TBI is a convergence insufficiency, where you cannot move your eyes together to bring them in and focus on that one subject in front of you. Again, that's where your vision therapist would come in. And then neurovisual rehabilitation really is a low vision specialty residency where you help patients who have end stage glaucoma, macular degeneration. They have end stage vision disorders, and so they can't see, and they're never going to really be able to see unless there is some sort of rehabilitation, some sort of device where you can measure and help them maybe magnify the letters in front of them, or maybe they have a peripheral vision disease where you need to help them kind of orient and mobilize. So you work with orientation motility specialists so that you can help the patient function in their real life. a patient who's had a stroke and maybe they have the right side of their vision is missing. And so there are special contact lenses and special glasses and special devices that can help move that missing field into the field that they're actually able to see. And so that all falls under neurovisual rehabilitation. So if we walk through a day in the life of an optometrist, so this is just limited to me. So obviously it will vary by setting. So I usually work about an 8 to 9 hour workday. I see about 30 to 40 patients a day. I don't want you to be afraid of that. In every setting, it's very different. You really can choose the setting that you work in. You can see anywhere between 10 to 12 patients a day to the caseload that I have, and really it just varies for anything in between. It also depends on what you do. I'm ocular disease specialist. I specialize in medical optometry. So I'm seeing patients on a very kind of fast-paced schedule, glaucoma, diabetes, macular degeneration, uveitis, cataracts, that type of thing. If you are a neurovisual rehabilitation specialist, you're going to have patients coming into you every 30 minutes because they need a longer evaluation, they need a more detailed evaluation, they need, you need to give that patient time to respond to your exam. And a patient cannot do that in the 15-minute exam that they have with me. And so obviously, it really just depends on what you do. Same with pediatrics. You're not going to be able to do a pediatric exam in 10 minutes. You definitely need a lot more time for that. Same with specialty scleral contact lenses for a keratoconus patient, for example. You need to teach the patient how to put a big, large 14 millimeter hard contact lens on the front of the eye. That's definitely going to take some time. So again, the number of patients will vary on the setting. I also do ancillary testing interpretation for, glaucoma, diabetes, macular degeneration, that kind of thing. And a lot of primary care optometrists will do that. Again, depends on the setting. And of course, you've got refractions and contact lenses, which is a part of optometry, but a small part of optometry, and definitely doesn't encompass the entire breadth of the profession and the spectrum on which we practice. And just a little tidbit here: complex cases keep me going. So the patient who has proliferative diabetic retinopathy and now has moderate stage glaucoma, and they need a retina specialist to do their injections for their proliferative diabetic retinopathy, and then I will be managing their glaucoma, and then from their glaucoma drops they have secondary ocular surface disease and they have allergies and dry eye disease. And so those are the types of complex cases where a patient has more than 3 or 4 types of conditions coming in, and how you treat the glaucoma is going to affect how you treat the dry eye disease, and how you treat the diabetes is going to affect the glaucoma. And so having that all encompassing type of multidisciplinary care is what really motivates me to keep going on the vein that I am. So we'll go into some case examples. I have a few slides of these. And so we'll just kind of look at pictures. Optometry and ophthalmology are very visual. And so we have a lot of testing that a lot of other healthcare professionals might not necessarily understand because it's so specific to the eyes. And also, we go by pictures because you get what you see when it comes to the eyes. And it's very complex and very interesting as well. So the first case on the left, I don't know if you can see my cursor, but I'm going to have you look at that picture first. So that's a herpetic dendritic keratitis. So that means is that the patient actually has a herpes simplex infection on the eye, and that's how it presents. It kind of presents with this dendritic ulcer. So it's this linear ulcer that has these end bulbs, these terminal end bulbs. And the way that they present, the way that they look is very pathognomonic for a herpes simplex keratitis. Now, unfortunately, if this is not treated, then it can lead to permanent vision loss or blindness. So you want to make sure that you're catching these early and treating them early as well. So this patient was treated with oral acyclovir, which is an antiviral, and also with topicals, and which was Zergan, ganciclovir. And this patient did very well, and that herpes simplex completely resolved. The second picture in the middle is an example of a corneal dystrophy, specifically Meesmann's corneal dystrophy. And so what this is very interesting. It's a dystrophy, so it's an inherited autosomal dominant condition. And it presents with these very small intraepithelial vesicles on the front layer of the cornea. So the cornea is the tissue that allows you to see on the front of the eye. It creates 2/3 of the focusing power of your eye. And it's made up of 5 layers. And right on that superior layer, that anterior layer, you have your corneal epithelium. Okay, and then you've got your basement membrane, and then your stroma, and then desmos and endothelium. And so you've got your corneal epithelium, and in this condition, you get these little vesicles, these little bubbles almost, and they're right in the epithelium. Okay, and a lot of times, this is not visually significant, but if it does become visually significant, meaning that the patient is having blurry vision and glare and sensitivity to light, and it's really interrupting the way that the light rays kind of focus into the cornea to project to the back of the eye, and the patient can't see. In that case, you have to go in and do like a layer scraping of the cornea. But a lot of times you just watch this. So it's interesting to see that, you look at the front of the eye, you're doing your eye exam, and you're not really expecting to see an autosomal dominant condition that presents in both eyes in your cornea. And it's something to educate the patient on. And it's a very interesting finding that you might not necessarily treat right away, but you might watch until the patient will develop symptoms. So that case really highlights that you don't have to treat everything that you see. It's also okay to observe until it becomes visually significant, which is something very different, for example, than diabetes, right? I mean, if you have a diabetic patient and you have a certain level of blood glucose, you have to treat that. So the eye can present with lots of kind of varying odd presentations, and we don't necessarily have to go and treat everything with surgery. The last patient here, this is a picture of the crystalline lens. Okay, so you've got your eyelids, which obviously are here with your cilia, your eyelashes, and then the light beam is actually focused on this dark area. It's called your pupil, and behind your pupil, you have your pupil is just a space. It's not an anatomical. It's not an anatomical structure. It's just a space, right? And then you've got your crystalline lens, which is where your cataract forms. So you might have heard of cataracts, and you can see this white kind of buildup of material right on the peripheral edge of the crystalline lens. And what that tells you is that this patient has pseudo exfoliation syndrome, or pseudo exfoliative material that's building up on the iris and the drainage system of the eye, and also on the crystalline lens. And so that's an interesting finding, because this patient can actually have an increase in their eye pressure, which can cause glaucoma. And it's very concerning when you see findings like this, because in these patients, the pressures tend to go up and down quite a bit. That's called fluctuation in the eye pressure. And if that's the case, then the patient will have a constant kind of compression up against the optic nerve, and that can cause permanent vision loss. So you have to watch these patients very carefully. And so all of these are completely within the scope of optometry. Obviously, these are examples of patients that I've treated. Okay, so then we'll go over to the picture on the left-hand side again. So this patient is looking down, and you pull the eyelid up and the patient looks down. And so you're seeing the limbus, just the edge of the cornea right there. And you kind of see this metal foot plate, right? Okay, so you can see, and it seems like it has like a little hole or a lumen that goes through it. That is called a mini express shunt. And that was placed in this patient. This patient has glaucoma. And so that was placed in this patient's eye to help drain the pressure from the glaucoma, relieve that pressure on the front of the eyes. And what ended up happening is that the tissue that was supposed to be covering it, which is a translucent mucous membrane called the conjunctiva, what happened was that the foot plate actually extruded through the conjunctiva, and now it's just an exposed metal plate in the patient's eye. Okay. And so obviously that opens this up, this opens this patient's eye up to a risk of infection, and you have to get rid of this right away. So this patient presented to me for the first time, and he said, I've had glaucoma surgery and this left eye never really felt quite right. And I'm concerned about my glaucoma. I'm on this host of medications for glaucoma, but every time I blink, I have this weird feeling as if there's something there, but I keep looking, and the doctor told me that my shunt, he calls it, was okay. So when I looked at it, then I could tell that it had extruded through that membrane tissue, and you definitely don't want that. You want everything kind of enclosed, especially when you're putting hardware in the eye. So this patient, actually, I referred to my glaucoma specialist, who was able to just surgically remove that foot plate and close up the conj. And now this patient is a lot more comfortable, and we have him controlled on medication. So he's doing really, really well, just being managed on MMT, which is maximal medical therapy. In the middle here, you're seeing a patient, which was shared with permission, obviously, of the patient's right eye. And you see this huge kind of yellow lesion. You think, uh-oh, that really looks like it could be problematic, right? You're seeing this lesion. It shouldn't be there. You shouldn't have to pull your eyelid down and then something kind of pops out, right? That we all know that that looks a little bit odd. And so that is actually orbital fat prolapse. So there's fat in the orbit, which is the orbital bone that houses your eye and your optic nerve, and there's muscles and fat in there, and that sometimes can just kind of break through one of the protective membranes, and you'll be able to see that fat. So only when you pull the eyelid down. If this becomes significant to the point that it is causing problems for the patient, where the patient cannot move their eyes in all directions of gaze, or there's redness or some indication that this might be more of a malignancy, then you have to get a CT of the orbit right away. I held on this patient. I did not get a CT, but we are monitoring her. And if I decide that this is either growing or changing in some way, and I am concerned that it might be becoming a malignancy, then we would have to get a CT. So I would just order that directly. And then I would also want to co-manage with an ENT specialist. So this is a really good case. Again, you don't have to jump on something and treat it and surgically remove it right away. It can be something that's benign. And if that's the case, then and you do want to collaborate with another healthcare professional, then optometrists can obviously do that. And then here's another, on the right-hand side, another picture of a corneal dystrophy. For some reason, the clinic that I was in this year had tons of these corneal dystrophies, which is, they're not actually common at all. And so this corneal dystrophy is actually called granular corneal dystrophy. And can you appreciate how very distinct the lesions are? And there's a very clear space in between every single lesion. And the way that they describe it, another name for it actually is breadcrumb dystrophy, because it kind of looks like breadcrumbs. I'm not sure if I agree with that, but it definitely looks like that, you can see the lesions kind of very, very obviously. So the interesting thing about this case is that this patient actually was not visually significant at all and had no idea that this was going on the front of her eye. And this is common with a breadcrumb-like corneal dystrophy, with a granular dystrophy, where because there is a clear space in between each of these deposits, it actually doesn't cause any visual significance. And it usually is, the onset is around the age of 40 and up. And so again, if it does, and they are in the stroma, so they're a lot deeper than the Meesman's dystrophy. So if they were very large and large enough to kind of push through from where they sit in the anterior stroma, to push through basement membrane, Bowman's, the basement membrane of the epithelium is called Bowman's. So to push through Bowman's and then to push through the corneal epithelium and create like a lumpy, bumpy surface on the cornea, and then the eyelid goes over it, and then you feel that foreign body sensation. If that's the case, then you do want to go ahead and scrape it, and that's called a keratectomy. And that's not very common with granular dystrophy. Okay, so the picture on the right, this is a picture of a patient's, on the left, On the left is an abnormal finding, and then on the right is a normal finding. So on the right, you've got a normal macular OCT, which is ocular coherence tomography. That's a lot of words. What does that mean? So basically, we have the technology. It's a scan that goes to the back of your retina, the light projects to the back of the retina, and you're actually able to take a cross section of all of your 9 layers of the retina. And on the right hand side, where you see that kind of U shape, that's the bang smack center of your vision. That's called your fovea. That's where all your cones are. That's where your central 20/20 acute vision comes from. That central kind of the bottom of the U shape. Okay. And if there are any abnormalities in the layers of the retina, then the OCT, which is the scan that I'm referring to, the tomography, that will be able to pick it up. So you'll notice how they're flat layers, they're all kind of adjacent to each other. There are no black or dark spots to indicate that there's any fluid leakage, any hemorrhages, things like that. Then you focus your attention on the left and you see that that looks a little bit weird because there's some black spaces and I'm not really sure what they are, and I'm not getting that nice U shape, right? That contour. I'm not getting that nice contour. So this is actually illustrating an example of vitreomacular traction. So I want you to think of the back of the eye, and I want you to think of the vitreous, which is the jelly-like structure that fills that hollow space right in the center of your eye, okay? And it's attached to different points in the retina. And one of those attachment points is that U, that fovea right in the middle. So your vitreous is attached to the fovea. And with trauma or some sort of inciting event, so whether that's trauma, whether that's age, surgery even, which is essentially trauma, what happens is that vitreous attachment kind of pulls on the retina, on the attachment point. And if it pulls completely, then you can have a retinal detachment, or you can have a retinal hole or a retinal tear, which I'm sure most of you have heard of. But if it doesn't pull completely, but it kind of teases the retina, where it's kind of just attached to it, but not pulling it directly off and just kind of creating traction on the retina, then we call that vitreomacular traction, where there's a focal adhesion, whether it's a small adhesion or a broad adhesion, and it might spontaneously detach, where the vitreous kind of detaches from the retina and then the retina falls back down. Or it could have a really tight hold on the retina and then pull the entire retina with it. Okay. And so this is an example of that early focal adhesion where I'm talking about, where you see these like bird-like wings, and that is the vitreous with the focal adhesion kind of pulling up and creating that force on the retina. And then that space it's just fluid. It's not air, obviously, it's fluid. And so this patient will have a vision of 20/25, which is only 1 line away from 20/20, which I think is pretty amazing. So this patient has no idea this is happening at the back of their eye. But when I do the scan and I do the dilated eye exam, then I can tell the patient that, hey, you are at risk of that retina coming off completely, and I do need to see you back every 6 weeks, every 3 months, whatever it is, depending on the severity. And we typically at 20/25 vision, which is only 1 line away from 20/20, you don't do surgery on this patient, because every time you think of surgery, you have to think about your risk benefit ratio, and the risk is this high and the benefit is this low right now. Why? Because the vision is so good. Okay. So you're not going to operate on an eye that has 20/25 vision. But you do consider watching this very closely, just in case this case does go downhill and the vision gets worse and worse. Or even worse than that it just pulls the retina off completely. And in that case, it will need surgical correction. And so you want to make sure that you're watching this patient closely for that. And also you educate the patient, you let them know, hey, if you are having blurry vision, and you want to test each eye separately every now and again. And if you do have that blurry vision in that eye, then I need to see you right away so that we can kind of do this test again and see if there are any changes. So that's a really good case to illustrate that patient could have no idea what's happening at the back of the eye and the vision unless you go get your eyes examined. You would have no idea that this is happening. And this is serious because it could actually lead to a retinal detachment, which is a very serious disorder. Okay, so we kind of move on to glaucoma. This is my favorite topic. I love glaucoma. Glaucoma is a disease of the optic nerve, which is cranial nerve number 2. And with glaucoma, what ends up happening is that you can get an increase of fluid buildup at the front of the eye that creates a translational kind of compressive force to the optic nerve. And the optic nerve is what you see from. It's the main cable. It has a million nerves inside the optic nerve itself, and it projects to the back of the eye. to the back of the brain, sorry, that will help you see. So if your optic nerve is damaged, you can bet that you're going to lose vision, and it's irreversible vision loss. It's permanent, which means that you have to do everything you can to detect and prevent early. So in this slide, what you're seeing on the left is a picture of the optic nerve of the right eye. And you can see kind of, you've got the one large circle, and then you've got kind of like a white circle in the middle. I call this, the analogy I give to patients is like a bagel, okay? And so you think of a bagel, you have a hole inside the bagel. Well, you want that bagel bread to be as thick as possible. That's how much bagel I want. I want the hole in the middle of the bagel to be very, very, very small. And I want to have a lot of bread in my bagel, okay? If you look at the picture on the left where my cursor is, that's the right eye. If you kind of trace in that circle in the middle of the picture of the optic nerve, if you kind of trace kind of like where that pink tissue is versus where that white tissue is, you can see that I don't have a lot of bagel here, okay? My bagel bread is very, very thin, and the hole inside the bagel is very, very, very large. I don't like that. That tells you that the axons are dying because of that high intraocular pressure inside the eye. And that is going to translate to permanent irreversible vision loss. You treat this, once you've detected it, treat it with eye drops, you treat it with laser, and then eventually you treat it with surgery. And so if you don't catch this early, then you are at risk of having that permanent blindness. Unfortunately, glaucoma doesn't have any symptoms, which is another reason we always educate that, patients need to have their eye examined even if they're not having any visual problems, because there are no symptoms to this. And so you could have no idea that this is happening at the back of your eye unless you actually saw those pictures and your eye doctor told you that you don't have glaucoma or risk for glaucoma. On the left-hand side, this is actually is a really nice picture. What this slide really demonstrates is just how optometry is integrated into the systemic health, okay? And so there's a medication called amiodarone, which is a calcium channel blocker that's used for dysrhythmias of the heart, cardiac dysrhythmias. And that medication can have a side effect, which is basically corneal verticillata. It's pigment deposits in the epithelium of the cornea on the front of the eyes, okay? Now, in the picture on the left, what you can see is kind of this brown circumlinear line right underneath the border of the pupil. And then it kind of goes vertically into the pupil as well. And it almost looks like a scribble, right? So this is a side effect of the medication. Sometimes patients don't always remember their medications, or they don't share their list of medications with every healthcare professional. So I looked at this patient's eye and I said, "Hey, I think you're taking amiodarone, right?" And the patient said, "Oh yeah, that's right. I did forget about that. Yeah, I see my cardiologist for that. And I have a heart arrhythmia." And then he said, "Well, how did you know?" And I said, "Well, because I see side effects of the amiodarone on the front of the eyes." And so obviously that's really impressive to the patient. But the take home here is that amiodarone side effect of corneal verticillata actually doesn't cause any visual problems. And so it's important as eye doctors that we're kind of noting that this is the change that we're seeing on the patient's front of the eye, but this is not going to be reason or cause enough that this patient needs to stop the medication for their heart arrhythmia. But just a really nice case to highlight that the eyes play a significant role in the rest of the body and the body's health, the systemic health. And eye care definitely needs to be a part of that conversation. It's the same with hydroxychloroquine, or otherwise known as Plaquenil. Okay, so everybody's heard of that medication now because of the whole media hype and everything with COVID back in, I think it was May, when they were saying that it was a treatment for COVID. And so that medication can have side effects in the retina, and so it's always nice when a primary care provider or rheumatologist has told the patient that you could have side effects and we really need to get you in for an eye exam so we can establish what your baseline is. Once we know what your baseline is, then we can monitor you on the hydroxychloroquine, and we can make sure that this medication is not causing any problems in your vision. And unfortunately, that is a medication that can cause permanent scotomas in the vision. And so that means that areas where the patient can't see, and those are irreversible, unfortunately. And so that is a medication that would 100% need to be stopped if you did see side effects. So certain medications do need to be stopped if you see ocular side effects, and then there's a group of medications that don't need to be, and amiodarone is one of them. Moving on to other things in the retina, the picture on the right shows an eye with a really big red blob right in the center of the picture. Okay, so that is a hemorrhage right in the center of the vision. That's called the macula or the fovea. And this hemorrhage is secondary to a condition called age-related macular degeneration. So Aomd is an age-related condition that is caused by, abnormal metabolism of the retinal epithelial cells in the retinal pigment epithelium, the RPE, in the retina. Okay, so that's one of the outer layers of the retina. And what can happen is that when you have abnormal metabolism, you end up with these waste deposits that are made of lipid and protein, and they're called drusen. And it creates a lot of dysregulation in that area of the retina, and it creates a bumpy surface on the retina. So when light hits a smooth surface, it converges nicely, you get a clean picture. When light hits a bumpy surface, light scatters and you get blurry vision. And so when you've got drusen building up at the back of the eye and it's creating a bumpy surface, therefore you have blurry vision. So once those drusen build up, not only do they cause blurry vision, but they also cause a dysregulation of metabolism at the back of the eye. And then you can end up having these new blood vessels that grow underneath the retina. And that's called a choroidal neovascular membrane, which can cause bleeding at the back of the eye. And if there's bleeding at the back of the eye, then that can cause vision disruption. Patient needs injections into the eye. And so you definitely would have to co-manage this case with a retina specialist. So this is a really great case, but also a little bit sad. Okay. So this is the same patient. The picture on the left is the patient's right eye. The picture on the right is the patient's left eye. So we'll start with the picture on the left. This patient is right eye has pretty normal looking retina right in the middle here. You see this sheen, that's an epiretinal membrane. You see this kind of these traction lines right here. That's all coming from the epiretinal membrane. But overall, this patient's right eye looks fine, and we're not treating it. We're not doing any surgery, and that's fine. And then you look at the left eye and you think, wow, that looks really different. What is that tiger spot looking lesion that's kind of taking up most of her posterior segment? Okay, so that lesion is actually it's a choroidal met. And so this patient had stage 4 metastatic liver cancer that metastasized to the choroid in the left eye. All right, so this patient came into us for a regular eye exam. She wasn't really having any problems. Her vision was 20/20 her in the right eye, and it was 20/40, which is 3 lines away in her left eye. And she said, yeah, I'm not really having any problems, but otherwise I'm doing fine. I've been feeling a little bit down, a little bit sick recently, but I'm not having any problems. Okay. So we saw this lesion, and this is a very scary lesion for an eye doctor to see. So we got her set up with an oncologist. She had PET scans, she had CTs of her abdomen, she had the whole thing. And she was diagnosed with a primary liver cancer. Okay. And the liver cancer had met to the choroid, which is the tissue underneath the retina. And that's that large lesion that you are seeing. So then she was sent to UCLA by my practice, and she received a plaque brachytherapy, which is a direct radiation onto that metastatic lesion. And she was doing well for about a year and a half, and her vision was stable, a good like 20/40, 20/50. She was doing fine. And systemically, she was doing well. And it wasn't really early enough to assess whether she was really truly in remission, but she was doing well, and she wasn't having any further extension of her liver cancer. So she comes back to me about every 3 to 4 months, and we kind of check her out. And so a few months ago, she came back to me earlier than her regular appointment. And she said, I don't know, but my left eye feels a little bit off, and I just want you to have a look. And now that she knows that, obviously this has been a very traumatizing event for her. So what you can see is your optic nerve, which is your circle, and then you've got your lines, your red lines are your arteries and your veins that are coming off of the optic nerve. And you see these white fluffy lesions on the optic nerve itself. And then you can definitely see a difference between both optic nerves. The left eye, the margins look quite blurry, but on the right eye, they're like very distinct. It's definitely a circle. You can see where it begins, you can see where it ends. So this patient actually ended up developing radiation optic neuropathy, which is a secondary effect of the radiation that she had done by directly to the optic nerve, which is the guy that's responsible for your vision. That's a very scary situation to be in. So my retina specialist and I, we looked into the literature, and it's actually a very rare condition. A lot of times you can have radiation retinopathy, but it's very rare to have radiation optic neuropathy, which is secondary effects on the optic nerve. And the literature really supports that unless the patient's vision has decreased by a significant amount, then you don't do anything, you just watch it. Okay. So we ended up sending this patient back to UCLA. And the retina oncologist at UCLA said, "Yep, I'm not going to do anything. I'm just going to watch it." And so now she's watching the patient and we are watching the patient as well. So when you have radiation to the eye, it can cause preferential loss of the vascular endothelial cells by releasing free radicals. And that can cause leakage and hemorrhaging and ischemia into the surrounding tissue. And that is what happened in this optic nerve. Um, I saw this patient a few weeks ago, and she's actually doing fine. Her vision has gone back to baseline, and some of these white, fluffy lesions, which indicate ischemia, they have actually resolved. Now, this patient is going to be at risk for developing radiation retinopathy, radiation optic neuropathy. Radiation treatment in general does not come without damage to collateral tissue, depending on where it's applied. And this is no different in the eye either. So she's going to require a very, very close follow up by myself and my retina specialist, and also the retina specialist at UCLA, so that we can make sure that this patient is doing well and doesn't go downhill. If she does start to go downhill, then we will administer intravitreal injections into the eye. The idea of that medication is to essentially stabilize the vascular endothelial cells so that leakage will slow down or hopefully even stop. That was a really interesting case, very sad for the patient's part, but she ended up doing well, which I'm very thankful for. And when you see these patients, quite often you get very attached to them. These slides are really nice examples of diabetic retinopathy and how diabetes can affect the back of the eye. So you look at that picture and you think, oh wow, that looks really bad. Um, and you are correct. And you can see lots of different changes that are happening at the back of the eye, from the diabetes. And the one thing I want to kind of focus your energy and your attention on is these little black spots right here. So this is laser. So in the color fundus photograph right here on the top, you can see that it kind of looks like maybe green or gray, but then when you look at the fluorescein angiograph pictures on the bottom, then you can see they look like black burn marks, and that's exactly what they are. Okay, so this is just to illustrate that diabetes can really affect the back of the eyes, and a lot of times as an optometrist, you'll see these patients come in where they've had laser to the back of the eye to help reduce the impetus of new blood vessel growth and leakage from the diabetes in the retina and on the optic nerve as well. And you want to make sure that you're co-managing this with your retina specialist, and that patient is getting fluorescein angiograms every few months to make sure that there are no new areas of leakage. So if you look at that picture on the right, you can see your optic nerve, which is again that circle in the middle, and then you've got your red lines or your vessels coming off of it. And then you can see that right in the middle, it kind of looks like there's a little white light on the black and white picture, which is your fluorescein angiograph. And what that's showing you is that there's actually neovascularization right at the optic nerve. This patient is in a lot of trouble. Okay, that's what that means. This is high risk neovascularization. This patient is going to need much more laser to decrease the impetus of new blood vessel growth to the back of the eye. Okay, so that kind of concludes the case presentation side of things. And now we're going to talk a little bit about how optometry differs from medical optometry, which is what my specialty is. So they're not different degrees, though the exact same degrees. I chose to do a residency in primary care and ocular disease at the VA, which really ramped up my clinical understanding of complex cases, because I was very involved in managing these complex cases. And so medical optometry is simply just a focus on medical management. It's a niche of optometry. Full scope optometry refers to the preference to practice to the highest level that your state regulation allows. So, for example, if I were in Oklahoma, I would be doing laser on my glaucoma patients, because that's the highest level of scope that Oklahoma State allows. Medical optometry includes management of diabetic retinopathy, glaucoma, cataracts, uveitis, red eye, foreign bodies, infections, that type of thing. Um, and then residency and fellowship, I say, are very, very helpful, not only in the realm of managing complex cases and ocular disease, but also in contact lenses and pediatrics and neurovisual rehabilitation. You learn a lot of these things in your 4-year optometry program, but if you want to specialize further and really enhance your education in those areas, then I would highly recommend that you do a residency and a fellowship through the AAO. So hopefully from this presentation, you have been able to glean that optometry has a very wide spectrum and wide scope, and it ranges anywhere from measuring glasses, prescription and contact lenses to full scope medical care to all those cases that I just presented. Full scope medical care typically involves co-management with ophthalmology. And so how does ophthalmology differ from optometry? And, ophthalmologists essentially can do most of what optometrists can do, except that most ophthalmologists cannot specialize or choose not to specialize in contact lenses and vision therapy and neurovisual rehabilitation because they are focused on surgery. So if you want to know what the difference is, that's the difference. It's the surgical aspect. So if you're interested in eye surgery, then it's worth exploring ophthalmology. If you're not interested in eye surgery, but you're interested in procedures and lasers and medical eye care, then it's worth exploring optometry. The political climate is changing as optometry advocates for more medical, more laser procedures. Now, it depends on your state regulations again. Optometrists are in a position because they are the primary eye care provider that they are co-managing with many different specialties, including internal medicine, family medicine, rheumatology, endocrinology, ENT, allergists, cardiologists, neurologists. Those are the most common that I will co-manage with, and in a lot of those cases, you could see that it would be very difficult to manage the patient with on Plaquenil without having spoken to the rheumatologist about it. And then many specialties such as vision therapy and neurovisual rehabilitation, they require a really in-depth understanding of the visual cortex and cortical functions. And so really what I want you to take away from this slide is that there are many paths that you can take with optometry. It really just depends on your scope of interest. So the one thing I'm sure you've all been waiting for is, well, what do you recommend for a pre-optometry student? I think when you're an undergraduate and when you're in high school, the biggest thing that I can recommend to you is shadow, shadow, shadow. I think it's a little bit tough now, which I completely appreciate. Pandemic won't be around forever, and well, at least hopefully. And shadowing experiences in different settings in optometry can really help you understand the scope. And once you're out of school, it can really help you understand what practice you would like to explore and which practice you would like to finally end up in. So I'd recommend a retail setting. I'd recommend an OD-MD setting. I'd recommend an OD-OD setting. And the way to do that is to reach out to your local optometrists, to your family eye care providers in the area, and just reach out to the doctor or the office manager, introduce yourself, offer to send in a resume, and just let them know that you are considering optometry as a profession, and that even if they could spare a couple hours a week, you would really be grateful. And then, of course, when you show up, please maintain your social distancing, wear a mask. You are, going to be around patients, and you want to make sure that you're respectful. And then obviously also ask the office manager and ask the optometrist, the eye doctor, if there's anything that you should bring. Make sure you're taking notes, be engaged, ask questions, and really make it worth your time. Even if you can do 1 or 2 hours a week for a 6-week stint, that will give you a really good idea of what an optometrist does in that setting. If you're in high school, I would say the same thing. I say there's absolutely no harm in trying to figure out if optometry is a path that you want to pursue as a high school student. So obviously you want to do well on your SAT and your ACT, and accumulate some volunteer experience as well. If you are kind of in between professions, maybe you're thinking more of ophthalmology, maybe you're thinking something completely different, this is the time to figure it out. So take your shadowing opportunities and really explore a broad spectrum of opportunities and careers, so you can really figure out whether this is something you want to do. Once you're in optometry school, then you would really want to participate in your volunteer opportunities, your screenings, try to do research. I say these things because I did all these things and they were really helpful. Build a network of seniors in your community, senior optometrists who are, out in the world practicing optometry. Never underestimate the power of building your network. You never know who you might need in the future, who might need you in the future. And so developing that network is going to be imperative. Of course, study for your boards and practice clinical skills as much as you can. If you need a tutor, student tutors are available. Really take advantage of those. Even an undergraduate, I tutored throughout undergraduate and through optometry school. And so if you find yourself in a position where you want to pull up your grade, or you need a little bit more like that one-on-one attention that your professor is unable to provide, get a tutor and really just make sure that you're setting yourself up for success as you go forwards. Okay, so does anybody have any questions for me?
So I have some questions just from people who've emailed us and who couldn't make it today. So one person asked, what kind of study methods did you use when you were in ophthalmology school and just studying?
So when I was in optometry school, the best thing that really worked for me was group learning. So I personally like to talk about things when I'm learning them rather than writing flashcards. So that's just something that works for me. Um, so I would study in a very small group, maybe a maximum of 1 or 2 people, and then we would just go back and forth and explain certain concepts to each other. And that was the best way that I learned. And then, of course, I would also have a set schedule for myself. The one thing I really struggled with was making a schedule that was completely unattainable. I felt like I always made a schedule where I would be studying, 10 hours a day. Don't do that. That's unrealistic. You have to work out, you have to make time for other you have to make time for other things in your life, in your day. And so make it realistic, make it attainable. And if you're one of these people who likes to check off something on list, make a checklist and then start checking things off. And that psychologically helps you feel like you're being productive as well.
There is a question in the chat. If you could answer that question, that would be great.
So are certain eye diseases or disorders more common than others? And if so, which diseases are the most common? Yeah, so cataracts are the leading cause of blindness in the world and in the United States. So you could say that's the most common, to answer your question. And then the second most common is of leading cause of blindness in the United States is glaucoma, which is why it's so important for you to advocate for your patients and send those patients in for eye exams, because both of those conditions can be easily treated and prevented in some cases. You're so welcome, Noor. Any other questions? How long did you study for the OAT for, and how did you schedule it all out? How long did I study for the OAT? I probably studied for about one semester, one whole semester. So what is that, maybe like 4 months. And so the way I would do it is for the first 2 months, I started out pretty slowly, where I would only study about 3 days a week. And I did have at that time Kaplan. Are you guys familiar with like Princeton Review and Kaplan and those types of courses? So if you are, then Kaplan, I was able to sign up for the OAT studying guide, and there were in-person classes that I also attended, and then they would have their own homework, and so you just follow their program basically. And if you don't feel comfortable at the end of their program to take the OAT, then you can kind of do the independent studying on your own, and then extend it for another semester. But I feel like 4 months was more than enough time really to do that. Um, and you really, I mean, the best way, Claudia, is you want to make a good attainable schedule for yourself. So if you feel that you need more than 4 months of studying time, let's say, because I believe I took the OAT, like I think it was like maybe sometime in December. So maybe start studying over the summer and start slow and then start ramping it up. And that's the way I would recommend doing that. Also, repetition. You want to just keep repeating the same material over and over again, because that's the only way that you're going to really be able to memorize it. Um, you're so welcome. Are the lesions you described reversible after treatment? Okay, so you usually treat to get rid of the lesion. So I guess to answer your question, you are reversing that treatment. You are reversing that disease process if you do treat it. Treatments will also have side effects as well, though. So your problem doesn't just go away if you, for example, treat an eye with laser, because it's a systemic problem for diabetes. So you do need to make sure that you're also um, treating your diabetes as well. That's a systemic condition. So everything's kind of tied together. Um, okay. I highly recommend not working full time while studying for the OAT. That's probably a good idea. Okay. Any other questions?
I just had another, like on your journey, what are some of the greatest challenges that you faced?
So, as a pre optometry student, I was having trouble at the University of Florida finding opportunities that were pre optometry specific. So, I created a program, I created an internship. So, I went to the VA and I shadowed the optometrists at the VA opposite my undergraduate school. And then I reached out to the program director there, the chief optometrist, and I said, hey, I'm really interested in optometry. We don't really have a ton of resources at the University of Florida for optometrists. We have an optometry group, but what shadowing activities can I participate in? And so I asked her if it was possible for me to start an internship program where I would recruit other optometrists to kind of staff the clinic. So not only did the clinic benefit from having these students come in and run all this ancillary testing and check patients in and things like that, but the students were also really gaining a lot of that real time, real life experience in what an optometrist does. And then once we had helped the doctors work up the patients in the clinic, we were actually able to sit inside the exam rooms and really watch that interaction between patient and doctor to get an idea of what what their role was when it comes to taking care of patients. And that's what propelled me towards medical optometry, because that was my first impression, my true first impression, apart from me going to my own eye doctor, of what I can do as a medical optometrist.
Thank you. There's
So,
another, yeah.
so there's another question from Haber. Why did you specifically choose optometry and not medical school? So I was pre-med for 3 years, and then I switched over to optometry school because I realized I shadowed an ophthalmologist, and I didn't love it. I didn't love the surgical aspect of it. Cataract surgery is very kind of like numbers based, and there's a lot of math, and I was more interested in really kind of tying systemic diseases and conditions together and focusing on rehabilitation. So once these patients come out of these surgeries, they need resources on how they can function and see. And I felt like I would make a more significant and substantial contribution to their lives if I was involved in the visual rehabilitation side of things. So really helping that pediatric patient with a hard contact lens at the age of 6 months, I felt like was very valuable to me. So that's why I chose that. And really, you know, when you're thinking about optometry versus ophthalmology, surgery is the biggest difference. If you're interested in surgery, then I would highly recommend that you explore that option. Any other questions?
Okay, I think that's it. So thank you so much for speaking with us today. You gave us a lot of great and interesting information, and your case pictures taught us a lot as well. So thank you so much
You're
for
so
coming.
welcome. It was great to be here. Thank you for all your great questions and thanks for your attention. If you have any other questions, feel free to reach out and I can definitely try my best to answer them. Okay, bye guys.
Thank you.